Welcome back to the deep dive. Today, we are tackling a topic that usually triggers an immediate instinct to change the subject.
We are diving into a topic people usually run away from.
Yeah, exactly.
Yeah.
It's the medical procedure that launched 1,000 awkward jokes, and I'm going to go out on a limb here, it's also this incredibly misunderstood feat of modern engineering.
It really is. I mean, it's the gold standard for cancer screening, but at the same time, it's this absolute masterclass in risk management and anatomy.
Right. We're, of course, talking about the colonoscopy. But before you cringe or tune out, stick with us. We are looking at this through a totally different lens today, based on a very specific source. It's a video transcript titled HCC 1475-13 Colonoscopy Sigmoidoscopy.
And that's from the YouTube channel Gautamukala S. Raju.
Yes, thank you.
Yeah.
And what makes this source so fascinating is that it is not a patient brochure.
No, not at all. It's essentially a behind-the-scenes look at the strategic decision-making that happens well before the patient even enters the room.
Which was the biggest takeaway for me, because I always just thought, you show up, you get the good drugs, you take a nap, and you wake up with a juice box.
Right, yeah, the magic nap.
Exactly. But this source reveals there was this whole pre-game strategy session. So our mission for this deep dive is to decode that session, to understand the hardware, the risks, and the surprising ways doctors actually perform surgery from the inside out.
It's highly sophisticated stuff, and whether you are approaching that screening age of 45, or you have a family history, or even if you're just curious about how medical tech navigates the human body, this is incredibly relevant.
It moves the conversation from just discomfort to the literal logic that saves lives. So let's start with the hardware. I admit I assumed a colonoscope was just a generic tool.
A one-size-fits-all kind of deal.
Yeah, you just grab the scope and go to work.
Yeah.
But the source makes it clear that is absolutely not the case.
Not even close. Before the procedure even begins, the endoscopist, the doctor, has to look at the patient's history and make a very specific choice about which instrument to use.
Right. And the source outlines 3 distinct types of scopes. And the decision comes down to literal millimeter.
Right, so let's go through the lineup. The standard workhorse is the adult colonoscope. This is what gets used on the vast majority of adult males.
Okay, and how big is that one?
It has an insertion tube diameter of 12.8 millimeters. It's sturdy, it has good torque, meaning when you twist your hand, the tip twists with it, and it navigates the standard anatomy really well.
12.8 millimeters. Got it.
Yeah.
But then the source throws a curveball and mentions a pediatric colonoscope, which my first thought was, okay, that's for kids.
Which is the logical assumption, but it's actually incorrect in practice. The pediatric scope is slightly thinner at 11.8 millimeters.
Okay.
And the source explicitly highlights that this is often the preferred instrument for women, particularly those who've had previous pelvic surgery.
See, that seems counterintuitive to me. Why would a surgery like a C-section or a hysterectomy mean you need a kid scope?
It all comes down to what happens inside the body after surgery. When you have pelvic surgery, you develop adhesions, which are basically internal scar tissue that sticks things together.
Right, like gluing things in place.
Exactly. It changes the angles of the colon. Normally, the colon is somewhat free-floating, but adhesions can tack it down, making the turns sharper and much harder to navigate.
So the standard adult scope is just too thick to make those tight turns without hurting the patient.
Precisely. The pediatric scope is more flexible and has a smaller turning radius, so it causes way less discomfort in those altered anatomies.
That makes total sense. But then there's a third option, which this source calls the slim scope. And this one is even tinier, right?
Yes, this is the 9.5 millimeter scope. You can think of it as the special forces tool. You bring this out for the really difficult cases, specifically what the source calls a fixed sigmoid colon.
A fixed sigmoid. Break that down for us.
The sigmoid is the S-shaped part of the colon right near the end. Usually it's floppy, but in some patients, maybe due to severe diverticulitis or prior radiation therapy, it becomes rigid, like a stiff pipe.
Exactly. Think of trying to push a garden hose through a concrete pipe versus a rubber tube. If the pipe is rigid and narrow, a thick hose will just loop up and get stuck. The slim scope can slide right through those narrow, fixed segments.
But here is where I got a little skeptical. I was thinking, if you use the skinny scope, the 9.5 millimeter one, don't you sacrifice functionality?
You would think so, right?
Yeah, like can you actually fit the tools through it to do the job?
That's the marvel of the engineering here.
Yeah.
The source emphasizes this exact point. Regardless of whether the tube is the thick 12.8 or the skinny 9.5, the biopsy channel, the little tunnel inside the scope where they pass the tools, remains a standard 3.2 millimeter.
Oh, wow. So you don't lose any utility at all.
None. You can pass the exact same snares, the same clips, the same biopsy forceps through the slim scope as you can through the adult scope.
That is really impressive. It sounds like the ultimate goal is simply to get to the end of the colon no matter which car you drive to get there. The destination is the cecum. That's the beginning of the colon where it meets the small intestine. The doctor has to document that they actually reached that landmark.
And if they can't?
If they can't get there because they picked the wrong scope, the exam is considered incomplete. So that pregame choice is absolutely critical.
Okay, so the doctor has picked the right scope. Now let's look at the patient file itself. Who is actually lying on the table? I think everyone knows the number 45.
Yes, 45 seems to be the magic birthday for screening now.
Right.
That is the current standard in the U.S. For an average risk individual, someone with no symptoms and no family history, you start at 45 and you keep going until age 75. That covers the vast majority of the population.
But the source spends a lot of time discussing the people who fall outside that window, specifically the elderly. It's not just a matter of keep screening forever, is it?
No, and this is where the medical decision-making gets really heavy. The source discusses a complex risk-benefit analysis for patients over 75.
Because if a patient is frail or has significant comorbidities like heart failure or severe diabetes,
Right, finding a small polyp that might take 10 years to turn into cancer probably isn't the priority.
because something else is likely to get them first, to put it bluntly.
Exactly. And the risk of the procedure itself starts to climb. But when you hit age 80, the source says the math changes dramatically.
This part really stuck with me. The source warns that for patients over 80, the risks aren't just getting a hole in the colon. We are talking about major systemic events.
Yes, we are talking about myocardial infarction, heart attacks, and strokes.
Wait, hold on. How does a camera in the colon cause a heart attack or a stroke?
It's the physiological stress of the whole process. The prep causes dehydration and electrolyte shifts. The sedation drops your blood pressure.
Oh, I didn't even think about the prep.
Yeah, and then the act of distending the bowel with air during the procedure can trigger a vagal response that actually slows the heart down. For a fragile 80-year-old cardiovascular system, that stress test can tip the balance.
So you could go in trying to prevent a cancer that might happen and trigger a heart attack that does happen right then and there.
Exactly. The source is very clear that in that age group, the procedure itself carries a real mortality risk. It forces an ethical conversation about when to stop looking for problems.
On the complete opposite end of the spectrum, you have the people who can't wait until 45, the high-risk groups. The source threw out some alphabet soup here, like FAP, Lynch syndrome, IBD.
Let's unpack those, starting with the genetics. FAP stands for familial adenomatous polyposis. This isn't just, oh, my dad had a polyp.
Right, it's much more severe.
These patients have a genetic mutation where they develop hundreds, sometimes thousands of polyps in their colon.
Thousands. That's hard to even picture.
It's like a carpet of polyps. For them, the risk of cancer is essentially 100% if they don't do something. The source notes they often use sigmoidoscopy for these patients.
Which is just looking at the lower part of the colon, right?
Right, because if you see hundreds of polyps there, you already know what's happening everywhere else.
Wow. And how does that contrast with Lynch syndrome?
Lynch is different. You don't get thousands of polyps. You might just get one or two. But the genetic mutation means your body can't repair DNA mistakes very well. So a single polyp can turn into cancer incredibly fast.
So for them, you need the full colonoscopy and you need it frequently.
Absolutely. And then there's the IBD group inflammatory bowel disease. That's Crohn's and ulcerative colitis.
And the key there is inflammation, right?
Yes. Chronic inflammation causes cells to turn over rapidly to repair the damage. Rapid cell turnover increases the chance of a mistake, a mutation, which leads to cancer.
And the source says if you've had the disease for 8 years, your clock starts ticking for screening.
Right, but there is one major exception. The immediate screen.
Oh, right. The scary combination. If a patient has IBD and a liver condition called primary sclerosing cholangitis,
Yes, PSC. The risk is so high with that combination that the source says you start screening the exact moment of diagnosis. You do not wait 8 years.
it really highlights that screening isn't a generic term at all. It's highly personalized. Now, usually when we talk about screening, we assume we are looking for cancer.
But the source makes a point that finding actual cancer during a routine screen is, thankfully, quite rare.
The real win in a colonoscopy isn't finding cancer, it's finding the precancerous polyp.
Exactly. You find it, you snip it out, and you have effectively broken the chain. You've prevented the cancer from ever existing in the first place.
But sometimes patients aren't there for a routine check. They have symptoms.
Mm-hmm.
And the source walks through some of this diagnostic detective work. The big one, obviously, is bleeding.
Bleeding is the absolute #1 alarm bell. But the type of bleeding tells the doctor where to look. The source distinguishes between bright red blood and occult blood.
Bright red seems the most dramatic, but I feel like a lot of people just assume it's hemorrhoids and ignore it.
And often it is, but the source stresses that you cannot assume that. Bright red usually means the bleeding is coming from the rectum or the lower colon because it hasn't been digested yet.
Right.
It could be hemorrhoids, sure, but it could be colitis, or it could be angioectasias.
Angio what now?
Angioectasias,
Yeah.
think of them like spider veins in your gut. They are dilated, fragile blood vessels that bleed very easily.
And the source mentions a specific connection here with prostate cancer, right?
Yes, patients who have had radiation therapy for prostate cancer often develop these bleeding vessels in the rectum years later.
That's a fascinating connection. So a prostate treatment 5 years ago could explain rectal bleeding today.
Exactly. Then you have occult blood. This is hidden blood. You can't see it in the toilet bowl. It usually shows up on a lab test as iron deficiency anemia.
So you're just tired, you take a blood test, and you find out you have low iron.
Right. If you are losing iron, you are losing blood somewhere. If it's not visible, it means it's coming from higher up in the GI tract, like the right side of the colon or the stomach, where it gets mixed in with the stool.
Which is a massive signal to go look for a cancer or a large polyp hiding up there. What about when there is no blood, just weird bathroom habits? The source mentions a specific pattern: new constipation mixed with occasional diarrhea.
That specific mix is a classic ominous sign. Think about the plumbing. If a tumor is growing in the colon, it acts like a partial dam.
Oh, I see. It blocks the solid stuff, causing the constipation.
Exactly, but liquid can still squeeze around the blockage, causing the diarrhea.
So you are backed up, but then having the runs, and you just think your stomach is upset, but it's actually a mechanical blockage.
Correct. It's a sudden change in pattern that demands a look. Or if you have chronic diarrhea, especially in young people, it's often irritable bowel syndrome, but you still need a scope to rule out colitis.
And there was also a mention of PTs scans, right? Like a technology crossover.
Yes, if a patient has an abnormal CT scan for some other reason and it shows a hot spot in the colon, you need a colonoscopy to go locate that exact corresponding abnormality.
Okay, so let's say the detective work pays off. They find the problem. Now they have to fix it. This is where the source shifts to therapeutic interventions, the surgery from the inside part.
This is where the technology really shines. They aren't just observing, they are actively fixing things.
The most common fix is removing a polyp. The description in the source for the snare resection was pretty vivid. It sounded almost like a carnival game.
It's essentially a wire lasso. They pass it through that 3.2 millimeter channel we talked about earlier. They loop the wire over the head of a pedunculated polyp, so imagine a mushroom on a stalk.
Okay.
They tighten the noose around the stalk, and then they pass an electric current through the wire.
So it cuts and burns at the exact same time.
Exactly. It cauterizes the tissue as it cuts to prevent bleeding. Snare, zap, retrieved.
But what about those bleeding spider veins? The angioectasias. You can't exactly lasso a flat blood vessel on the wall.
No, you can't. For that, they use something called argon plasma coagulation, or APC.
Which sounds incredibly sci-fi.
It is very cool. Think of it like a tiny flamethrower, but instead of fire, it uses ionized argon gas. The gas conducts electricity.
So the probe doesn't even have to touch the tissue.
Right. It sprays this purple plasma beam that zaps and seals the bleeding vessels on contact. It's often used for that radiation telangiectasia we mentioned.
That is wild.
Yeah.
And then there was one more intervention that confused me at first. The source talked about treating strictures and placing stents.
Right, let's clarify that. An anastomosis is the connection point where two pieces of bowel are stitched together after a surgery. Sometimes that connection heals too tight and scars down. That narrowing is called a stricture.
So the plumbing is pinched shut.
Exactly. The endoscopist can slide a deflated balloon into that narrow spot and then pump it up with water pressure to stretch and crack that scar tissue open.
Widening the pipe from the inside.
Yes.
Yeah.
And for malignant obstructions caused by tumors, especially if a patient has metastases to the liver and can't have major surgery, they can place expandable metal stents to hold the colon open.
It is just amazing that all this happens through a flexible tube while the patient is napping. But here's the reality check. It's not risk-free. The source dedicates a significant amount of time to adverse events.
It is a medical procedure. Things can go wrong. First, you have sedation monitoring. You have to constantly check heart rate, blood pressure, and oxygen to catch arrhythmias or aspiration.
And then the biggest physical fear is perforation, poking a hole in the colon.
That is the most dreaded complication. It can happen mechanically, literally pushing the scope too hard against a sharp turn in a weak colon so it stretches and tears.
Or a thermal injury, right?
Yes, when they use that electric snare to burn off a polyp, if the burn goes too deep, it weakens the wall and a hole can open up days later.
And if that happens, the symptoms are severe abdominal pain and fever.
Yes, and the source says you need an X-ray or CT scan immediately. If you see air under the diaphragm, free air, it means there's a leak.
Though the source mentioned, if the perforation is small and clean, they might just close it with flips right then and there, avoiding major surgery.
They can, yes. Antibiotics, bowel rest, and clips can sometimes save the day.
But here is a risk I had never heard of before. Splenic injury. I didn't even know the spleen was involved.
It's rare, but it happens because of anatomy. The spleen sits tucked way up in the upper left corner of your abdomen. The colon has to make a hairpin turn right next to it called the splenic flexure.
So they are very close neighbors.
Very close. If the colon is attached to the spleen by adhesions, or if the doctor pulls on the scope too hard while navigating that turn, it can tear the capsule of the spleen.
And the symptom for that is bizarre. The source highlighted it specifically. Abdominal pain accompanied by left shoulder pain.
That is a classic medical quirk called referred pain.
How does a bleeding spleen make your shoulder hurt?
It's the wiring in your body. The phrenic nerve, which controls your diaphragm, originates in your neck. If the spleen bleeds, it irritates the diaphragm. The brain gets confused and interprets that diaphragm irritation as pain coming from your left shoulder.
That is a huge deep dive detail for you listening. If you wake up from a colonoscopy and your left shoulder hurts, you tell the nurse immediately.
Absolutely. It triggers an immediate need for a CT scan. Oh, and we also have to mention the hide-and-seek risk.
Right, where lesions can literally hide behind folds in the colon and be completely missed.
Exactly. It's why careful technique is so important.
So let's talk about the recovery. The procedure is done. You're in the recovery room being monitored. What are the discharge orders?
The source lists specific warning signs for the family to watch out for. Bleeding, severe pain, fever, but also cough or shortness of breath.
Why the cough?
That points to aspiration pneumonia. Since you were sedated, you lost your gag reflex. If you had secretions or burped up stomach fluid during the procedure, it might have gone down into your lungs. Prevention is key there, keeping a suction catheter ready.
And what about delayed bleeding? The source mentioned post-polypectomy bleeding. You aren't out of the woods just because you left the hospital.
Right. Remember the burn from the snare? It creates a scab. Just like a scab on your knee, it eventually falls off. When that happens inside the colon, it can bleed.
So a patient could start passing fresh bloody metachezia or even faint from blood loss days later.
Yes. Usually it stops on its own, but if it's severe, they have to go back in and inject solutions or put a clip on it. Rarely intervention by radiologists or surgeons is needed.
It really circles back to the skill of the team. It's this delicate balance of aggressive screening to find the bad stuff, but careful technique to avoid creating new problems.
That really is the synthesis of this whole topic. It's not just finding things. It's about choosing the right tool, like that pediatric scope for the pelvic surgery patient, and knowing the right timing.
So what does this all mean for you listening? If you're 45, get it done. The technology is amazing and the scope is chosen just for you. If you have symptoms, especially that mix of constipation and diarrhea, do not ignore them.
And if you're taking a loved one for the procedure, pay close attention to those discharge instructions.
It certainly is a fascinating journey to the cecum and back. Now, before we wrap up, we always like to leave you with a final thought. Something to mull over.
We talked a lot about the incredible mechanics today, but I want to go back to that statistic about patients over 80.
Yeah.
The source was explicit. The procedure itself can trigger heart attacks or strokes in that demographic. It raises a really difficult ethical question for modern medicine.
Right, because we push for maximum screening in our culture.
Exactly. We have these incredible tools to find and fix problems. We want to know everything. But the source reminds us that there is a tipping point. For a fragile 85-year-old, the quest for the diagnosis can actually become more dangerous than the disease itself.
It's a powerful reminder that sometimes the most sophisticated medical decision isn't to operate or screen, but to gracefully do nothing at all.
Exactly.
A perfect thought to end on. That's it for this deep dive into the complex world of colonoscopies. Thanks for listening, and we will catch you next time.